Hi guys, my name's Catherine and I did my project on homocystinuria. I'm excited to share with you guys today. I enjoyed learning about this disorder and I hope you just enjoy this presentation. All right, so to get started, just an overview. It is a metabolic disorder. It is autosomal recessive. The word homocystinuria literally means an increased amount of homocysteine in the urine. Actually, nowadays it's primarily detected looking at homocysteine levels in the plasma, but it was originally using a urine test. So the most common type of this disorder is caused by a mutation in the CBS gene, the cystathionine beta synthase gene. So that gene is responsible for producing the CBS enzyme, so the enzyme with the same name. That enzyme acts in a chemical pathway and is responsible for converting homocysteine to cystathionine. There's other things produced in this pathway, other amino acids, including methionine. So basically, when the CBS gene is disrupted, it messes up the whole pathway, and as a result, there's a buildup of homocysteine in the blood and also excreted in the urine. So that's how we get homocystinuria. So as I mentioned before, it is autosomal recessive, which we know that means both copies of the gene have cell mutations. The parents usually have an individual with a recessive condition, each carry one copy of the mutated gene, but they don't have signs or symptoms. And that's how it's passed down. I did think it was interesting that with homocystinuria, you can, if you have one normal copy of the CBS gene but one mutated, that you will not be diagnosed with homocystinuria, but you'll be more likely than other people to have a vitamin B12 and folic acid deficiencies. So you could still have some health issues, things that can be rectified easily, but still some health issues, which is kind of interesting. So we'll go more into detail on this pathway. Here is the methionine metabolic pathway that I was talking about earlier. So it shows exactly how the CBS gene, CBS enzyme plays a part right there under the homocysteine, and how if it's messed up or mutated, then the whole pathway is thrown off. And that's how we end up with more homocysteine in the urine. Okay. So now that we know the basics of this disorder, we can talk about how we diagnose it. We talked about if there's increased homocysteine in the plasma and urine. The most normal way to have it diagnosed is with a newborn screening. With newborns, they actually look for the increased levels of methionine, which I thought was interesting, instead of the homocysteine. But because we looked at that pathway earlier, we know that it still makes sense that it's going to come to the same conclusion. If that gene is disrupted, there's going to be an increase in those levels. Any newborns with abnormal screening of methionine should be tested for homocystinuria. So the only other way that newborn or babies are diagnosed typically is if they start having multiple organ disease in infancy, and then they're going to be tested for a range of things, obviously, but that includes this disorder. All right, and so let's focus a little more on newborn screening. They use either a dried blood specimen or a plasma analysis. It just depends on the screening. If their levels for methionine are high and it comes back as positive, then they will test for homocysteine, so a second tier test to make sure there's no false positives. Pretty much all infants with homocystinuria, the classic kind, which is the CBS deficiency we're focused on, detected by these screenings, have pyridoxine non-responsive homocystinuria, which pyridoxine is vitamin B6. So it means they're not going to respond to B6 supplements. So it's pretty rare for them to be diagnosed but respond to B6. The best results are obviously when you are diagnosed as a newborn and they can really start focusing on your treatment right away. Okay, so moving on to signs and symptoms. The ectopia lenitis is the most common and most obvious symptom. It usually occurs around the age of 8. The myopia can occur at 1 year old, but that's going to be a lot harder to detect and diagnose because you're talking about, a toddler, a 1-year-old who already doesn't have like fully developed eyesight, you're not going to know probably that they're that nearsighted, but it will be like extreme nearsightedness compared to other 1-year-olds. Like I said, it would just be hard to diagnose. There's going to be vascular abnormalities. There can also be skeletal abnormalities. The skeletal abnormalities actually can present a lot like Marfan syndrome. So like extremely long limbs, scoliosis, increased height, which I thought was interesting. But the one like factor that sets it apart is going to be there's no joint hypermobility with homocystinuria like there is with Marfan's. So that is definitely worth noting. As far as the seizures, they can occur in up to 21% of untreated individuals. So not super common, like the dislocation of the lens of the eye, but still worth noting. And then there can possibly be developmental and learning disorders, but that's not always present either. It just kind of depends. As far as the prevalence, it's not super common, so because it is recessive, I did put some of the countries where there were higher numbers. Qatar is interesting because they do have a large Arabian population, and part of their culture is the consanguineous relationships, which we did discuss earlier in this class. We talked about it and we wrote responses about it and everything, and how it is a big cultural thing for first cousins to marry. And because of this reason, because in the Qatar they do have that Arabic population, then they're going to be more likely to pass down this recessive gene. So I wrote a little bit in my response a few weeks ago about that, about how genetic counselors really focus on education and just talking to people and not necessarily trying to disrupt their culture or change anything, but just educating on things like disorders that could occur in their children, such as homocystinuria. And it's pretty common there for it to be 1 in every 1,800. It's pretty prevalent. So this is my picture of my pedigree that I did on it. It just kind of shows how it can be passed down. It would be different, obviously, if there were consanguineous relationships and if there was first cousins marrying, then that would obviously change things quite a bit as far as how it's passed down. So you guys can see that there. So moving on to treatment. I mentioned earlier that a lot of newborns are diagnosed to be unresponsive to the B6 vitamin. If they are responsive, then they just have to take B6. They recommend around 200 milligrams a day. So not too bad, but most of them are not going to be responsive. So then they're going to have to do a methionine restricted diet. And even most that do take the B6 are still going to be on the methionine restricted diet just because it's a smart thing to do. This diet is for lifetime, so it's not just like something that can be corrected. Obviously, we know because the gene is mutated. You want it to be diagnosed by a metabolic dietitian, so someone very specialized in this area. Like I said, most B6 responsive individuals are still on a methionine restricted diet just for control. Let's see. Basically, it's going to talk about natural protein intake and how much should be taken in through the diet. It's just going to be a lot of supplements and a lot of very specialized diet. So then the other part of that is you don't want to have protein malnutrition. So they're going to add in other amino acids like cysteine and that sort of things through supplements. So that's kind of what the dietitian would focus on. There's also going to be regular ophthalmology visits for the eye disorders like the myopia and the dislocation of the lens, and just to keep an eye on everything because you don't want anything to progress without you monitoring it. DEXA scans are also going to be important because they have very brittle bones and should be performed every 3 to 5 years just to kind of keep an eye on everything. And then I just thought this was interesting. I found as I was reading these articles because there was definite things to avoid with this, and one of them was oral contraceptives for females because they can increase their odds of having a thromboembolism. So that is a major health concern with these patients. That's usually the cause of death as adults, is they were undiagnosed as a child and have a thromboembolism as an adult because they do have some issues with blood clotting. It also mentioned that surgery should be avoided, which I found was very interesting because if you do have brittle bones, then obviously the odds of you breaking that bone and having to have surgery can increase, especially if it's a child. So they have to have like this special ID, which is or IV, which is 5% dextrose in point 0.5 saline, 1.5 times maintenance before, during, and after surgery. So I just thought this is interesting because if a kid breaks their arm and has to go in for immediate emergent surgery and they don't even know that they have this disorder, then they could get the wrong kind of IV and it could just cause all kinds of problems down the road. So that's why the newborn screening is super important, just so they have to have it. That you have it diagnosed before you even go in, and if there is an emergency situation, at least you're prepared. It is kind of a catch-22 because that thromboembolism is still like always a present worry. So you want to avoid surgeries in general just because they're blood clotting issues, but then they're also more likely to have like an accident and need a surgery. So that was kind of sad. But in general, I hope you guys enjoyed listening to my presentation. I hope you learned a little bit about homocystinuria, and I'm looking forward to watching you guys. Thanks.